So, hi everyone, uh, especially to my fellow batchmates and my respected seniors. So, today I'm going to talk about the HIP examinations. So, if I made any mistakes, please guide me. So, because in the coming times, I have to present some cases. So, all that I am going to practice today only. So, first of all that you have to take the patient name as sex and all the demographic data, all the your mm, occupation, all that. Then comes to the presenting complaints mainly you can see in the hip joint, mainly the pain on the hip, that is main complaint. uh, Other than pain is the mainly you can say is it is the around the your he will say the I have hurt on the hip, like C sign, that you can say I have hurt on my groin. Sometimes he will say like that. And other than that, the pain may be the radiating. So where the pain is radiating, maybe it is radiating to the back, or maybe it radiating to the knee. So mostly it will radiate to back, maybe radiate to back, because uh, hip pain may be present with the back pain also. So vice versa also, hip back pain also present with the hip pain also. In knee pain, if it is hip pain presenting with knee pain, that's mainly presenting in the children's. Okay, children's may have the knee pain in the when he's presenting with the hip pathology. So that's why we have to drill the pain. Other than pain, patient may complain of limp. Limp is someone is saying you are walking like that. You are not walking normally. You are limping. So whatever he is saying is in his language. So you are limping or you are not walking normally. So that is the thing. In limping or other than limping is maybe deformities, how the deformities onset and progressions, all that you have to ask. Other than that, deformity, he may present with the what to say, that is your swelling that is not common in the hip, maybe present sometimes swelling. That is more common maybe in the fractures sometimes, but in hip pain, swelling is the not that common, I think. Then comes to the other parts of the examinations. So first of all, in history, you have to tell onset, where is instead is onset gradually progressive like that. Then whether it is a relieving by rest or medications. So all history you have to tell whether if a patient went to that hospital and patient took that treatments, patient took steroids, all that, and patient took whatever that treatment, patient went to the local practitioners. All that story you have to tell in the history. So after that, all that you can tell that patients whether it is a relieving by the rest or medication, or aggravating by the your walk during walkings, all that. Then all about that. If a patient have stiffness, then it may be related that whether he can sit cross leg or sit on squatting position or not. If it is sit in the squatting position or sit in cross legs, you can simply you can rule out hip pathology. He will not have hip pathology if he is sit on the cross leg, and as well as he is uh, uh, sitting in the squatting position. So you can safely rule out that things, I think. Then after that, all the your that whether there is any other diurnal variation in the pain or not, we can talk about that. And in the end, of course, uh, how the patient, that very important, patient initially walking how much and now he can walk how much, whether he can walk or not, that is very important. Whether he wheelchair bound or he can walk, or how much he used to walk. Sorry, how much he used to walk initially and now how much he walking now, that is very important. Let's say an example, how he walking initially 2 to 3 kilometers, now he hardly walking around 100 meters, 200 meters, so he have to take rest after that. That that also important in the history. Then so all these things, then you have to take rule out the fever, weight loss, loss of appetite, all that things. After that, what are the I'm telling what are that some simple questions that can be asked in the examinations. What are the causes? Oh, that is maybe the your inflammatory cause. So inflammatory cause, you have to rule out. The main thing is the night cry. What is night cry? During the night, when patient is sleeping, there will be muscle tone get relaxed. Muscle get relaxed. So there will be overriding of the joints, articular surface of, okay. So that will be, there is more pain on the during nights, in especially in infection like tuberculosis, and so that is night cry. Other than infection, it may be the inflammatory like rheumatoid arthritis, all that patient may have history of RA, all that. So inflammatory is there. Iatrogenic is there. Iatrogenic means previously he has maybe any operated patient of THR or any other thing that may hampered his blood supply of head of the femur. So that may be the thing to be iatrogenic. That is not that common, but it can be happen. Iatrogenic also can be there. Other than the traumatic, previously he had any trauma or not, you have to ask that. Other than that, maybe the uh, inflammatory traumatic. Other than that, maybe your drug related. Maybe he taking previously any steroids or any other drugs that may have hampered his hip. So he may be taking for any conditions like COPD or any other like RA, he taking long term steroids. So that may be the thing you have to ask about drug related. Okay, then other than that, maybe your simply that maybe more cases coming your uh, like that, you have that what to say, I forgot that, but leave it. That okay. Then these are the main common things in the your hip that may cause your hip pathology, or may maybe secondary drug related may your okay. So other than that, you have to go to the examination now. Examination proper. In examinations, what you have to see, first of all, on the standing, then lying down or sitting down. Three phase of the examinations. On inspection, you have to see the on standing on the front. On the front, standing in front, you have to see coronal balance of the patient. The head is the center, shoulder the same level, all these. Okay, head is center not, or your shoulder is same shoulder is same level or not. If shoulder is deep down one side, it may be due to the secondary to the any your spine problem like scoliosis, all that. So other than that, you have to see the position of your ASIS, see the wasting of muscles, see the position of the patella, see the position of the ankle. So all that things in the front. Then in the side, again, it's inside sagittal balance. You have to see whether it is a negative sagittal balance or it is positive sagittal balance or it is normal. So, okay, or other than that, you have to see the your exaggeration of lumbar lordosis on the side, and any wasting of muscles also can be seen in those side, like thigh or calf muscles. So these are the main thing in the side examination. From back you have to rule out all the scoliosis, from side also kyphosis can be seen from side. I'm sorry, kyphosis, yeah, kyphosis, and as well as exaggeration of lumbar lordosis, all that. From back, your scoliosis, all that can be assessed. Then your level of the PSIs or your gluteal folds, all that can be assessed from back. And of course, your wasting muscles, all that. Okay, that is from standing. Then sitting. Sitting is the all about compensatory mechanism. So, for example, you have scoliosis, but not seen in standing, but it's, it's seen in standing, but it's compensated in the sitting down. For example, you have PSI is higher on the standing, but it is compensated on the sitting down. All about sitting is compensatory mechanism. Lying down also you can examine patient. So on inspection heading also you have to remember that you have to keep in mind your any scars, dilated veins, uh, any other things. Okay, skin conditions, whether it is a redness or not. All these things you have to keep in mind on inspection. Other than that, we come to the palpation. So on palpations, when you come into the palpations, so some important test is there. First of all, the Thomas hip flexion test. In Thomas hip flexion test, very important. First of all, we can talk about the our vascular sign of Narath. What is the vascular sign of Narath? I'm talking about some test only now. So all the other things are later. Vascular sign of Narath is nothing but it is a femoral pulse is absent or not. That is we have to see vascular sign of Narath in the your femoral triangle or whatever is Karpa's triangle, whatever. So that is absent femoral pulses, then it's positive vascular sign of Narath. Other than a very important test, that is a Thomas hip flexion test. Thomas hip flexion test is nothing but it is when lying down the patient, then as the opposite hip is flexed, knee and hip flex, and holding that position, then you see the obliteration of the lumbar lordosis. It is obliterated not, then see the whatever the deformity, fixed flexion or fixed whatever, fixed flexion deformity his patient has or not, or the whatever. If it is you want to know if it is due to the knee or the hip, then you take the patient on the edge of the table. Okay, that's all about the Thomas hip flexion test. It's a very important test. Other than that, your branch triangle, nothing but keep your thumb on the ASIs, other two finger on the one is on the GT, one other in the other side. Parallel to this ASIs, that is your brand triangle. Brand triangle supra trochanteric pathology. Other than that, nilateral line is very important. So that shows the bilateral pathology, and nilateral line is the mainly it is from the pubic your striatum to the ASI's line joining. So other than the Shoemaker's line is there. Shoemaker's line is the nothing but it is from the ASIS to the GT to ASIS, ASIS to the umbilicus, whether the line joining the central node. That is the main thing about Shoemaker's line. Other than that, many other tests like your telescopic test, just flex the hip and knee at 90-degree. Keep your palm and your thumb on the GT, palm play down, other thing play down, and feel that you can just do this moment. You keep your hip to above and down, keep it down or above hip, and see, feel these GTs, position of GT. Okay, that is the your telescopic test. Other than that, many other tests is there. So these are the main things. Then other than that, if I missed many things, I missed, I think, but I directly jumped to the test. I missed the feel part. I think palpation, all that. Uh, and I also missed the sorry about that. Very very sorry. I am not that experienced that these things. I missed the gate. Gate you have to tell in the front. So what about the gate? Very important thing. It's a very important gate. Gate is the nothing but you walking. How is walking? You are walking. Okay. So first of all is a Trendelberg, your antalgy gate. Antalgy gate is your shoulder drooping opposite side. You are walking like this. Your shoulder droop opposite side. Okay. To pathology. Pathology is, suppose pathology is in the left side, your shoulder droop is right side, like you walking like this. So that is your antalgic gait. Or if it is just dropping same side, if you have pathology left side and your shoulder dropping left side only, then it is your short limb gait. As means same side, your shoulder drooping same side, and that is short limb gait. As same short limb gait. Okay, you're dropping like this same side. Okay, left side pathology, shoulders drooping same side. That is your short limb gait. Other than that, that is very important. Trendelberg test. Trendelberg gait. Okay, Trendelberg gait is nothing but when your legs. Okay, what is the Trendelberg gait test? When you standing up and you stand on the your leg, one leg, your affected leg, and your opposite leg. It's if it is sag up, then it is okay, no problem. But it's fall down, then it's positive test. Okay, so this fall down, then you have to make this large, compensate this fall. You have to make this large. This large, if it is large there, then it is your Trendelberg gait. Okay, if it is large, to compensate opposite fall down of this ASIS, because your weak abductors, your like medius is weak, liver arm is weak, so it is you have to compensate that is your trend blood test. Other than then you have to do both palm like that, and other patient is more weight on the other side, then also is positive some side. Then other than that, your gluteal folds also can be assessed. Other than that, you have to keep palm on the front of the keep your thumb on the front of the ASIs, then ask the patient to sit on the one leg, then if that's below that it is positive, it's up, negative. So these are all the about gate. Other gate also be there. Circumvention gate is there. Intrusion gate is there. Uh, many other gate is there, but that not that important. I think. Okay, so these are all about today. Other thing we have to look in next class. Okay, bye bye.